Welcome back to this series of lectures in neurology. Today we'll be going on and discussing about a very important topic, which is seizures and epilepsy. So let's begin. So what is the difference between a seizure and an epilepsy? So what is a seizure? A seizure is a transient occurrence of neurological symptoms due to abnormal excessive electrical activity in the brain. So transient occurrence of neurological symptoms due to abnormal excessive electrical activity in the brain is called as seizures, right? So each and every word is very important. So abnormal electrical activity in the brain can trigger transient neurological symptoms, and this is called as a seizure. Now what is epilepsy? So if two or more seizures occur more than 24 hours apart, two or more seizures, you have a seizure today, you have a seizure tomorrow, right? So two or more seizures happen more than 24 hours apart, then it becomes a epilepsy. Okay, so or epilepsy can also be defined as one unprovoked seizure with a 60% chance of recurrence in the next 10 years with EEG and MRI changes. So there are EEG and MRI changes, then you can suggest that this seizure is probably going to be an epilepsy. Apart from this, we have something called as epileptic syndromes, which are usually seen in children. We have something called as epileptic syndromes, which are usually seen in children, where you can have developmental disorders and other associated abnormalities along with your epilepsy. So that is called as your epileptic syndrome. Fine. So this is a seizure versus epilepsy. Seizure is basically one episode when more than two or more episodes occur 24 hours apart, right? So that is called as an epilepsy. Fine? Okay. Now let us understand the etiology of seizures in detail. So the etiology of seizures depends upon which age group is affected, right? So we will be looking at each of the etiologies according to their different age groups. So in neonates less than 1 month of age, what can be the cause of seizures? The cause of seizures very importantly can be due to perinatal hypoxia. Cause of seizures can be due to perinatal hypoxia, ischemia, intracranial hemorrhage. Basically all of this is because of birth trauma. Birth trauma can cause a oxygen cutoff to the brain and it can result in seizures. Similarly, presence of CNS infections or metabolic disturbances. Many of the children who are born with, let us say, glycogen storage disorders or any other form of amino acid disorders, amino acid metabolism disorders. So all of these can predispose to seizures. Then other metabolic disturbances including hypoglycemia, electrolyte disturbances like hypocalcemia, hypomagnesemia, pyridoxine deficiency, all of these can cause neonatal seizures. Then developmental and genetic disorders, very important, developmental and genetic disorders. So these are about the various etiologies in a neonatal age group. When it comes to infants and children more than 1 month less than 12 years of age, the most common group is your febrile seizures. So the seizures which occur during an episode of fever. Apart from that, again, genetic disorders, epilepsy syndromes, developmental disorders, trauma, all of this can contribute to seizures even in the early childhood. In adolescents 12 to 18 years, again, genetic disorders, infection, tumors and illicit drug abuse can also contribute to seizures. Whenever you have a drug withdrawal, for example, alcohol withdrawal itself can cause seizures. Okay. In young adults 18 to 35 years of age, again it is almost the same, and as the age increases more than 35 years of age, then the etiologies become slightly different. So as the age increases, there is an increased risk of CVA, right? So cortical strokes, cortical hemorrhage, all of it can cause seizures, right? So CVA. Then tumors, alcohol withdrawal, metabolic disorders, Alzheimer's disease, degenerative diseases and autoantibodies. Presence of autoimmune encephalitis can result in seizures in the older age group, right? So this is about the various etiologies. So according to the age group, you will have to see which etiology will be probable in the patient. So when it comes to the drugs which are associated with seizures, remember alkylating agents which are used in your chemotherapies, then antimalarials like chloroquines, antibiotics associated with seizures. What are the antibiotics associated with seizures? It includes beta-lactams and quinolones, so be very, very careful. Acyclovir INH, opioids. So many a times when we do a procedure, we give parenteral opioid without asking whether there has been a history of seizure in the past. So if the patient is not on an anti-epileptic medication, the opioids can precipitate a seizure. Then immunomodulatory drugs and like cyclosporin, tacrolimus and antipsychotic agents. So please remember the list of common drugs which can cause seizures. Drug withdrawal like alcohol, barbiturates, benzodiazepines. The withdrawal of all of these drugs can also result in seizures. Okay, so this is about the various etiologies of seizures. Now let us come to the classification. The classification of seizures is brought about by the ILAE, International League of Association of Epilepsy. 2017 classification is what is used, right? So this classifies the seizures based on the onset. It classifies the seizures based on the onset as focal onset, generalized onset or unknown onset. So it can be because of a focal onset where only the seizures is happening in one part or one limb of the body, maybe the face, maybe the limb. Generalized onset is when the seizure at the onset itself affects multiple parts of the body, or it can be unknown onset. Now focal seizures are classified as focal seizures with awareness or focal seizures with impaired awareness. The previous term which was being used for this is your partial seizures, which is not being used now, and this was classified as simple partial seizures and complex partial seizures, right? So your complex partial seizures term is replaced as focal seizures with impaired awareness. Okay. Now the focal onset of seizure can be of multiple types. You can have a motor onset and a non-motor onset. Motor onset begins with a motor symptoms. So you can have automatisms, you can have tonic movements, you can have clonic movements, myoclonic movements or epileptic spasms. Non-motor onset means that you do not have any motor sign, but you have other symptoms like emotional, sensory disturbances or cognitive disturbances or behavioral arrest, which is all your non-motor onset. Similarly, generalized seizures can also be motor or non-motor in onset. It can be tonic, clonic, myoclonic, atonic and epileptic spasms. The non-motor onset GTCS with a non-motor onset is what we call as absence seizures. So GTCS with a non-motor onset is what we call as absence seizures. Absence seizures can also be classified as typical, atypical and myoclonic seizures. So it can be classified as typical and atypical. So absence seizures, especially your atypical absence, can be easily confused with your complex partial seizures, or what is the new name? It is your focal seizures with impaired awareness. So what is the difference we will be looking at? Again, there can be an unknown onset. Okay. So this is about your new classification for your epilepsy or your seizures. So we have focal onset and generalized onset. Fine. Now let us look at focal seizures. So first is your focal onset seizures with intact awareness. Focal onset seizures with intact awareness, right? So these focal seizures basically can be of motor or non-motor onset, right? So motor onset means maybe like a flickering movement of the hand. So there is just some flickering movement of the hand where there is apparative movement and then it stops. So it is focal at onset, right? How it progresses is a different issue, but it was focal at onset. It did not start in the entire body, it started in one limb. So that is your focal onset. So you can have tonic, you can have clonic, you can have tonic clonic, you can have myoclonic. Tonic means prolonged contraction of the muscle. Clonic means there is a relaxation as well. Okay, tonic clonic seizures means there is alternate contraction relaxation of the muscle. And then myoclonic means sudden jerky movements. So this is the way we classify the focal onset seizures. What is the meaning of Jacksonian march? Now once there is a focal onset of the seizures, maybe like a movement like this, soon the movement spreads throughout the entire limb and it can also become generalized. So this spreading of the epileptic activity, of a focal onset seizure is what we call as your Jacksonian march, right? Some of these focal onset seizures, they can have an accompanied weakness, and this is what we call as Todd's paresis. So followed by the seizure you can have a weakness of that particular limb, especially if it is a focal onset. This is called as a Todd's paresis, and it can mimic a stroke because it can cause hemiplegia. It can mimic a stroke, but the Todd paresis will recover. A hemiplegia is not going to recover. Then the other term that you should know when we have focal onset with intact awareness is that epilepsia partialis continua. Epilepsia partialis continua means that there is a partial epilepsy, but it continues for a very, very long time. It continues and can go even into a status, and this is what we call as epilepsia partialis continua. So this is about the various features of focal onset seizures with intact awareness. Now, many of them can also have an aura. Aura, as we discussed in our migraine chapter, it is basically subjective symptoms. Aura basically refers to subjective symptoms which are not seen by the other individuals, right? So what are the types of aura that you can have? So you can have hearing defects or olfactory auras. They can have some smell kind of abnormalities. Then you can have deja vu, fear, micropsia, macropsia. Suddenly objects appear smaller or bigger. You can have a lot of fear. So these kind of auras can be there even with a focal onset seizure. Okay. Now, how is a focal onset seizure with impaired awareness different from a focal onset seizure with intact awareness? So in a focal onset seizure with impaired awareness, you have an aura, then you will have a stare and automatisms like lip chewing, this kind of movement, or lip smacking, this kind of movement can happen, right? So aura or followed by a blank stare, they will be staring, and there is automatisms like your lip chewing or lip smacking movements, and sometimes they can have versive head turning as well. They can have head turning as well. So the head turns to one side and they are staring and they have automatisms, right? Followed by which they have anterograde amnesia. They are not aware of this focal seizure at all. They are not aware of that episode at all, right? So this kind of focal onset seizures with impaired awareness, you will have aura followed by automatisms and anterograde amnesia for the seizures, right? So there is a transient loss of consciousness in which they are not at all aware. They have automatisms and they have anterograde amnesia. What is the EEG finding of your seizures in this case? There will be epileptiform sharps or spikes. So whenever we speak about the EEG discharges, this is how we basically indicate the diagrams. So sharp wave basically comprises of a sharp spike like this. A spike is usually narrow in diameter and more pointed, a little broader is your sharp. So this is a spike, this is a sharp wave. So here can you see you have a spike and a sharp, you have a spike and a sharp wave. So multiple spikes within 1 second is a polyspike pattern, and this is a polyspike and wave pattern. So this is about the different types of discharges that you can get. So you in a focal seizures, you can have epileptiform sharps or spikes, right? So can you see here in this that there are sharp waves which are basically present only focally. Only one part of the brain is getting activated in the EEG, not generalized. The rest of it has a normal background. So this is about your focal seizures. Okay. So this is about your focal seizures. Now let us understand what is your absence seizures. Absence seizures, as we said, is a type of generalized seizures. It is a type of generalized seizures. It is a type of generalized seizures with non-motor onset. Generalized seizures with non-motor onset. So it can be classified as typical absence and atypical absence. So what are the characteristic features of a typical absence seizures? Typical absence seizures is characterized by a sudden brief loss of consciousness without loss of postural control. There is no loss of postural control. Suddenly the patient is unaware of his surrounding and there is a loss of consciousness which lasts for only seconds, and there is no post-ictal confusion, right? There is no post-ictal confusion. So following the seizure, they are not confused. So just for few seconds, there will be some stare, blinking, and they are back to normal. Okay, so it has very, very subtle motor signs. You do not find any kind of major motor activity in your typical absence seizures. So this usually affects the children between your age group of 4 to 10 years, and it has a frequency of more than 100 times per day. So many of the times a typical absence seizure, how is your child going to present? The teacher is going to say the child is inattentive in class, the child is inattentive in class, or he is having a daydreaming kind of state. So this is how they will complain to the parent, and this is the reason. Reason is it lasts for few seconds and the frequency can be as high as 100 times per day. So that is your typical absence. Now what is your atypical absence? Your atypical absence is of longer duration. It's not just for a few seconds, it can go on for a few minutes, and it has more pronounced motor signs. It has more pronounced motor signs. Okay, fine. So the EEG in a typical absence is going to show your characteristic 3 Hz spike and wave pattern. So what does that mean? You have a spike and a wave, spike and a wave, spike and a wave, and 2 lines basically represent 1 second. 3 Hz means what? In 1 second you have 3 discharges. In 1 second you have 3 discharges, means that this is a 3 Hz spike and wave pattern. So spike and a wave, spike and a wave pattern. Okay, so that is the characteristic EEG finding of your typical absence seizure. In an atypical absence seizure, the EEG shows a slow spike and wave, a slow wave which is less than 2.5 Hz. You do not get your characteristic 3 Hz spike and wave pattern. Okay. So, how is your atypical absence different from your focal seizures? Okay, focal seizures with impaired awareness. So, how is it different? Right? So focal seizures with impaired awareness, what happens? They have aura, very important, they have aura. Aura is not present in your atypical absence. Aura is not present in your atypical absence. Also, next, they have anterograde amnesia. They have anterograde amnesia in your focal seizures with impaired awareness. But in your atypical absence, you do not have anterograde amnesia. You do not have anterograde amnesia. So, there is no post-ictal confusion. Okay, fine, right? Automatisms is more common in your focal seizures with impaired awareness. Automatisms is not there in your atypical absence. Okay. So these are the most important differences clinically. How do you differentiate if this is focal seizure with impaired awareness or an atypical absence seizure? Okay, so this is how you clinically differentiate it. Fine, so this is clear. Now let us understand the GTCS. So what is GTCS? This is generalized tonic-clonic movement. So this is your generalized tonic-clonic seizure. So it has a generalized onset, right? So this can be characterized by an aura. Aura can be different types of aura. It can be scotomas, it can be hearing deficits, it can be olfactory deficits and so on. So different types of aura can be there, followed by which they go into a tonic phase. Tonic phase means that there is a continuous contraction of all the muscles. So when you see at the onset of a seizure, if you have seen anyone having a seizure, the body becomes stiff. The body becomes stiff. So the entire body becomes very stiff. This is because they go into this tonic phase. Now a tonic contraction of the laryngeal muscles. A tonic contraction of the laryngeal muscles results in an cry which is called as the ictal cry. So most often if the patient is alone, it is this ictal cry which the family members notice and run to the patient and they inform the doctors as well. Okay, fine. There can also be tonic contraction of the jaw, and this can result in a tongue bite. So if the tongue gets stuck between the teeth and the jaw, it can result in a tongue bite. Followed by the tonic phase, they go into the clonic phase. Right? So followed by the tonic phase, they go into the phase of clonic phase where there can be relaxation. Right? There can be relaxation of the muscles and there can be tonic-clonic phase where alternate contraction and relaxation happens. There can be alternate contraction and relaxation of the muscles, and that is why you get these jerky movements that you see in your generalized tonic-clonic seizures. So you will get this jerky movements. Apart from all of this, there is also increased sympathetic activity. So you can have increase in the heart rate, there can be increase in the blood pressure and increase in the respiratory rate as well because of increased sympathetic activity during a seizure. Right? So this phase happens for less than 5 minutes. So most of the time the seizures recover within 5 minutes, and during this entire phase there is loss of consciousness. They are not aware of this. And followed by this you have post-ictal phase where you have post-ictal confusion. The patient will not be aware of what happened during the seizure. The patient may appear confused for some time, and after which there can be recovery. Also, followed by the sympathetic overactivity, the parasympathetic system sets in, and hence you can have urinary incontinence as well. You can have urinary incontinence as well. Fine. So this is about the different phases and manifestations of a generalized tonic-clonic seizure. On the EEG, you will find generalized low voltage fast activity or a polyspike pattern, which basically affects all the leads of the EEG. Okay. So this is about your GTCS. So let's move on to the next type of seizures. The next type of seizures is atonic seizures. As the name suggests, there is loss of tone. There is loss of tone and the patient presents with drop attacks. So the sudden loss of tone and they fall down, and the EEG shows a spike and wave pattern which is diffuse and a slow spike and wave pattern. Okay, fine. Then we have myoclonic seizures. What is the meaning of myoclonus? Sudden jerky movements are called as myoclonic seizures. Always rule out a metabolic cause whenever you see myoclonic seizures. For example, hypoxia, hypoglycemia, right? Hypoxia, hypoglycemia, electrolyte disturbances, all of these can result in myoclonic seizures. Physiologically, when do you see a myoclonus? When you just go to bed before you enter into the REM phase, you can have myoclonic jerks. Many of us would have experienced that. That is the same kind of myoclonus which you get in your myoclonic seizures as well. EEG again shows a slow spike and wave pattern. Then the last type of motor manifestation is your epileptic spasm, where you have brief sustained flexion and extension, right? So this is basically present in your West syndrome, which is a pediatric epileptic syndrome, where you have something called as salam spells. Salam spells means there is a sudden flexion of the neck and the head droops forward. The head droops forward, and this is what we call as your epileptic spasm, which is seen in your West syndrome. Okay, so this is about your epileptic spasm. And what is the characteristic ECG finding? You find hips arrhythmia. You find hips arrhythmia, which is a chaotic ECG. So you have large amplitude complexes which are very chaotic, and this is seen in your West syndrome. Okay, fine. So this is about the various seizure types and what are the types of clinical manifestations that you get. Now let us understand about the differential diagnosis of seizures, and the most important one is your syncope. This is your syncope. And how do you differentiate a seizure from a syncope? Right? So a seizure is usually does not have any precipitating factors, whereas syncope can have emotional stress, orthostatic hypotension and cardiac etiologies. All of it can present a syncope. Sorry, please cut the last line. All of it can precipitate a syncope. So in syncope also you have a transient loss of consciousness. In syncope also you have a transient loss of consciousness because of global brain hypoperfusion. Okay, so you have transient loss of consciousness because of global brain hypoperfusion, which can be because of stress, orthostatic hypotension, cardiac etiologies and so on. So no precipitating factors are usually found in a seizure, right? So you do not have some premonitory symptoms like aura can be there in epilepsy, but you do not have many premonitory symptoms, but tiredness, nausea, sweating, and you can have tunneling of vision. If any of you have fainted after standing for a long time in your school assemblies, you will remember what is a syncope. So you can have tiredness, nausea, sweating, tunneling of vision, and then you have a brief loss of consciousness, right? So posture at onset can be variable. You can have a seizure even while sitting. Most often syncopes are usually in your erect posture. Then transition to unconscious is often immediate, but this can be gradual or over a few seconds. A patient having a syncope will actually stand for some time and then fall down. Duration of unconscious can be minutes, but in syncope it can be up to a few seconds. The moment they fall down, they may be able to regain their consciousness as well. Okay, tonic-clonic movements are present in seizures, which may be present in syncope also. Remember, tonic-clonic movements may be present in syncope also, but they are never more than 15 seconds. So very brief tonic-clonic movements can be present in a syncope as well. Facial appearance, cyanosis, frothing of the mouth because of obstruction, the tongue falls back. In a seizure, you can have all of these symptoms, but here you mainly find pallor. Disorientation can be for long time, postictal confusion. Here the postictal confusion is not present, it's very minimal confusion which lasts for less than 5 minutes. So you have very minimal confusion which lasts for less than 5 minutes in a syncope. Tongue bite is there in both. Here you have a lateral tongue bite in the case of a seizure, and you have a tip tongue bite. The tip of the tongue can be bitten in case of a syncope, but it is rare in syncope and it is more frequent in a seizure. Urinary incontinence can sometimes be present in both. So it's very important what are the features that you use to differentiate a seizure from a syncope. What about the EEG? If you ever do a syncope, EEG will be normal if you ever do an EEG for a syncope, but most often you can clinically differentiate it as well. Now, what are the other differential diagnosis? Syncope we have already discussed. Psychogenic seizures and hyperventilation, panic attack can also result in a seizure. This psychogenic seizure is also called as your conversion disorder or pseudo seizures. Then metabolic disturbances like delirium tremens, hypoglycemia, if the sugar falls less than 60, they will be unconscious for a long time. Psychoactive drugs, especially or hallucinogens. Then migraines, especially basilar migraines, transient ischemic attacks, sleep disorders like narcolepsy, cataplexy, movement disorders like tics and paroxysmal choreoathetosis. And in children, you can have night terrors, sleepwalking, breath holding spells, and cyclical vomiting syndromes. All of these are your seizure mimics. Okay, this is about your differential diagnosis for seizures. Now let us look at the approach to seizures. So how do you approach a patient who is presenting with the first episode of seizure? So if it is an adult patient presenting with the first episode of seizure, always do a history and physical examination. Always do a thorough history and physical examination. Rule out your differential diagnosis like acute psychosis, migraines, transient ischemic attack or syncope. Rule out all of this and ensure that you are dealing with a seizure itself. Right? Now, if the patient has a history of epilepsy in the past and the patient is on treatment, patient has a history of epilepsy in the past and the patient is on treatment, then you will have to assess the adequacy of the drug that he is on. You will have to assess the adequacy of the anti-seizure drug that he is on. You will have to consider, is this because of a side effect? Is this because of a withdrawal effect? Is this because of a toxicity? Hence, you may have to do the serum levels of the drugs that he is on. Okay, fine. Now, after that, you have to do a complete metabolic workup, CBC, calcium, magnesium, glucose, liver, renal functions, urine analysis and toxicology screen to see if there is any new cause which has precipitated a seizure. If all of it is normal and there is subtherapeutic levels, then you will have to increase the dose of the medication. Most often, you do not need to do all this. If you ask a thorough history, patient may have skipped a medication and hence seizure would have got precipitated. In those cases, you do not increase the dose. You just have to counsel the patient about compliance. Okay. Now, if the patient has been taken his drug properly and the levels of the drugs is also within the therapeutic range, therapeutic drug levels, then you may have to consider whether you want to change the drug. Right? If there is any abnormality in the neurological examination, then you will have to identify it, do an MRI, do an LP, identify the cause. Now, there is no history of epilepsy. The patient is presenting with a first episode of seizure. Then again, you will have to do a laboratory analysis and rule out all the metabolic causes. right? If the positive metabolic screening is there, or if there is an infectious cause that you are suggesting, right, then you will have to do a lumbar puncture, you will have to do a CT scan, MRI scan, and treat the metabolic abnormality and consider a short-term anti-seizure therapy, maybe like around 6 months, and then you can taper and stop it. Okay. So if there is mass lesion, stroke, CNS infection, you have to treat the underlying cause. Now, if the metabolic screen is negative, you do an MRI and an EEG. The MRI in an EEG will help you identify what type of seizure you are having, like focal seizures or any other type of seizures. Then, if you found out that there is an epilepsy syndrome, if there is any evidence of epilepsy syndrome, then you treat according to it. Otherwise, it may be idiopathic type of seizures and you consider with drug therapy. Consider starting an anti-epileptic therapy. You may not have found a reason. They can be idiopathic causes as well, right? So this is about your entire approach to seizure disorders. Then we will be moving on into how do we manage seizures.